Our next group of speakers is a group of three speakers who really speak to our federal partners, three of our federal partners. I'd like to first introduce Dr. Richard McKeon. Dr. McKeon is a clinical psychologist and chief of the Suicide Prevention Branch with the Substance Abuse and Mental Health Services Administration, SAMHSA. In this field, he has spent his career working in community mental health, including 11 years as director of a psychiatric emergency service and 4 years as associate administrator and clinical director of a hospital-based community mental health center in Newton, New Jersey. He also established the first evidence-based treatment program for chronically suicidal borderline patients in the state of New Jersey. Please welcome my dear friend, Dr. Richard McKeon.
Good afternoon. It's an honor to be with you today to talk with you about suicide prevention, and my role is to put it in a bit of the context of our national efforts to reduce suicide. And I will also briefly touch on some international work that is also going on. I think you can move to the next slide. There. Yep. So 2 years ago, the World Health Organization, for the very first time, published a report urging the nations of the world to adopt within their nations systematic efforts and national strategies to reduce suicide. The estimate is between 800,000 and 1 million people worldwide lose their lives to suicide. So this report is subtitled A Global Imperative. So suicide prevention is an imperative around the world in every nation, and certainly in the United States, as the Institute of Medicine said in 2002. It is a national imperative for all of us. I'm going to try to make the following points today. I'm going to say that there are three critical elements to reducing suicide in the United States. And as you heard earlier, the 2014 data showed that over 42,000 Americans lost their lives to suicide in 2014, the last year in which we have data. So these are what I would say are the three critical elements. And these elements are incorporated throughout the United States National Strategy for Suicide Prevention. And this is what it looks like. It was issued jointly by the National Action Alliance for Suicide Prevention, and you will hear later from the Action Alliance, and jointly by the Action Alliance and the Surgeon General's office. The co-chairs of the effort were former Surgeon General Regina Benjamin and my colleague Dr. Jerry Reed from the Suicide Prevention Resource Center, who's with us, who gave untold hours to try to put together this comprehensive blueprint for reducing suicide in the U.S. But it would not be helpful for me to go over with you every objective that's in here, because there are many, because we need a comprehensive approach to reducing suicide. So let me break it down into these three critical elements. The first element is that we need to get better at identifying people at risk in our communities and connecting them to the care and supports that they need. Data from the National Violent Death Reporting System has shown that an estimated 27% of men and 47% of women have had recent mental health contact, defined as within the last 60 days. So that means that almost 3/4 of men and a little over half of women who die by suicide are not having mental health contact close to the time of their death. We need to get a lot better at being able to identify people and to connect them to the help that they need. The second area is that once people are connected to care, we need to be sure that that care is as evidence-based, as safe, and as systematic as it can be in terms of utilizing everything that we know about suicide prevention. Because those same numbers that I just quoted to you, so 27% of men and 47% of women have had recent mental health contact. So we owe it to them to make sure that mental health contact is the best that it can possibly be. And that means excellent treatment of the underlying conditions that are drivers of the person's suicide, things like major depression, substance use, etc., but also suicide-specific care that focuses on having a systematic approach to screening and risk assessment, the availability of evidence-based treatment that utilizes safety planning, that pays attention to access to lethal means, that looks at surveillance and quality improvement on an ongoing basis. And the Veterans Administration deserves a lot of credit because these are the key components that the Veterans Administration began to implement back in 2007, and which we at SAMHSA are trying to encourage more broadly in the behavioral health care system using an approach called the Zero Suicide Initiative. The third major area that I would say that we need to pay a lot more attention to and get a lot better at is improving care transitions. And improving transitions in general. Transitions play a huge role. You've heard today about transitions between the Department of Defense and the Veterans Administration as one key area. But there are other areas that are important. And of particular importance are transitions that take place between care systems and that take place after a suicidal crisis. And Thomas was alluding to some of this kind of work, because some of the strongest evidence in suicide prevention is that if you intervene after people are leaving inpatient units, after they're leaving emergency departments, after a suicide attempt, or after a suicidal crisis, for example, that may be encountered on the suicide hotline, that if you intervene after that period of time, that you can have an important impact. This was first underscored for me back when I was a psychology intern. I was a psychology intern in the Yale system, and I was working in outpatient treatment with a man who we were very, very worried about. We were very worried about him because we knew that he had the capacity to kill himself, to allude to some of the really important work that Thomas Joyner has done talking about suicide capacity and capability. He had made a near-lethal attempt. So we knew it was possible for him to do it. As a result, we had a fairly low threshold for a hospitalization. If he started to say he was thinking about suicide, we put him in the hospital. So we hospitalized him at one point in time, and then I left to return to my university at the University of Arizona to defend my dissertation. I was gone about 8 days, and when I returned to my internship setting, I found that he had been discharged from the hospital. Within 48 hours of the discharge, he had taken a massive overdose of tricyclic antidepressants and had died. So this was a very early experience about the importance of that time of transition in our work. And our systems nationally are not well set up to provide that care. And VA has also been a leader in looking at care and transitions, particularly for people leaving inpatient units. Now, I started by alluding to the importance of identifying people at risk in the community. Well, when I worked at Community Mental Health, this was also underscored for me when I set up an in-service for our Community Mental Health Center staff on suicide prevention. And I asked our local medical examiner to come and do a presentation and to talk with us about what the medical examiner had learned from people who died by suicide within our county. So he did that, and to my surprise, we hadn't talked enough about how she was going to approach it. She showed the death scene for each of these suicides, which kind of took us aback and was very poignant. But one of the things that struck me was that there was only a portion that I knew anything about. And we were the community mental health system. Almost anyone who received mental health care in our county we knew about. And I knew every single one of the young people who died by suicide, either because they had touched our care system or because the school had reached out to us after the suicide. But the majority of the suicides were older people who had never touched our system, who we knew nothing about. I still remember very poignantly one scene, which was of a person who had drowned themselves, and all was there was a walker. And that was the picture of this older person, and I realized how many people we were missing, how many people were there in the community that we need to find better ways to meet. Now, in youth suicide prevention, which SAMHSA has a major effort for, we have shown some successful results showing that we have reduced suicide deaths and attempts among young people aged 10 to 24 in counties that have implemented our youth suicide prevention activities, mostly community-based work, compared to matched counties who would not. So this was really encouraging. We were able to show we were saving young lives and preventing attempts. But there was a problem. The problem was that effect only lasted for 1 year. When you looked in the second year, it was gone. What that meant is that suicide prevention isn't and cannot be a one-and-done effort. Suicide prevention needs to comprehensively engage the entire community, and it needs to be sustained over time. It needs to be an ongoing focus. Now, there's a lot of work we need to do better work in the community around suicide prevention. We need to do better work at identifying who needs to be involved and how, what are the sectors, and what is it that we are asking them to do, and what will be the most effective. A lot of more work needs to be done in that area, but good work has been going on already. I should also mention that one of the things that SAMHSA is working on this year through our National Survey of Drug Use and Health, which is a household survey that's able to just generate estimates for the nation on people who have seriously considered suicide, made suicide attempts, made suicide plans. We also ask about veteran status. So one of the things we're working on this year is being able to generate estimates for the number of veterans who have suicide for the nation as a whole, not only those within VHA services, but those who what their numbers would look like who have seriously considered suicide, made attempts, and made plans, as well as to cross-reference that with other key information, such as mental health service utilization, major depressive episodes, drug and alcohol use. So, and we look forward to collaborating with the VA about some of the data that we have, as well as continuing to work with you about the great data systems that you have put together. The next thing I want to just go back over again is in talking about how we can make our care even better than it is. And there are numerous components that the VA has implemented and that we're looking at pushing out across the nation through the Zero Suicide initiative. And some of the early adopters of this approach that was started at the Henry Ford Healthcare System and other places such as Centerstone, one of the largest public behavioral health care systems, has been able to show a reduction of about 60% in the number of suicides of the people who are under their care. That's a very encouraging start. More work needs to be done. And I would also want to say that crisis lines, crisis intervention, suicide hotlines have a critical role to play in all this. One of the components is the kind of care transitions I talked about before. And we have found through our National Suicide Prevention Lifeline that we have worked closely with the Veterans Administration, that if you call 1-800-273-TALK and press 1, you're connected to the Veterans Crisis Line. And SAMHSA has provided small grants to crisis centers to follow up with suicidal callers after after the end of a call. Because the model for suicide care on hotlines used to be kind of one and done, that there was either an emergency response, maybe you gave the person a referral, but that you didn't necessarily follow up after them. We have tried to promote ongoing contact in that way, and some of the data from our hotline evaluations have shown that this is greatly valued by suicidal people who are working to connect with systems of care that we refer them to afterwards. So what I would like to do to end is to just summarize by saying there's a lot of tremendous work going on. We know more now than we've ever known before. We're doing more than we've ever done before, but we haven't gotten to where we need to go to drive suicide down across the nation. The way I would like to end is by reading to you the dedication that's part of the National Strategy for Suicide Prevention. To those who have lost their lives by suicide, to those who struggle with thoughts of suicide, to those who have made an attempt on their lives, to those caring for someone who struggles, to those left behind after a death by suicide, to those in recovery, and to all those who work tirelessly to prevent suicide and suicide attempts in our nation. We believe that we can and we will make a difference. Thank you.
I'd next like to welcome Dr. Alex Crosby, who is here from the Center. He's a medical epidemiologist in the Division of Violence Prevention at the Centers of Disease Control and Prevention. Thank you so much for traveling up here today. During his career, he has responded to numerous public health emergencies and led investigative teams addressing adolescent suicide clusters, civil unrest, school-associated violence, sniper attacks, firearm-related injuries due to celebratory shooting, and the public health response to Hurricane Rita in the Gulf Coast. He has authored or co-authored over 75 publications, and his work as a medical epidemiologist focuses on prevention of suicidal behavior, child maltreatment, intimate partner violence, interpersonal violence among adolescents, and assault injuries among minorities. He also had the rather unenviable role of being the supervisor to our own Dr. Robert Bossert. Are you still here, Rob, or did you leave for fear of being embarrassed? And he just stepped out. Well, too bad. So say whatever you want. Welcome, Dr. Alex Crosby.
He didn't come back in yet? Okay. Anyway, I want to thank you very much for the invitation, for Dr. Thompson, for Rob Bossert, also for Secretary McDonald, Dr. Sutton. I thank all of you, and definitely what we saw, at least from this morning, the leadership that came in, especially our elected leaders, and their commitment to doing something about the problem is encouraging to me, to see that we do have people at some of the highest levels of government and those of you who work in nonprofits and other kinds of organizations committed to doing something about this problem. My subject today is to try and convince you about why data collection, especially public health surveillance, is important. And those of you who heard, especially Senator Rounds this morning, already started talking about that stuff a little bit today. And so I'm going to kind of enhance on that just a little bit and talk about that and how that's an important issue for us to try to address. Many kind of jump towards doing programs. And while programs are important and doing prevention is important, in order to really do that well, and in order to be successful in implementing programs, you really need to collect the data, you need to analyze the data, you need to be able to disseminate that data, distribute it to those who need to know, so that you can implement successful programs. If you don't have the information, your programs are not going to be very successful in terms of identifying who's at risk, identifying those populations that need the most help, and then in finding out whether those programs are actually working or not. So those things are very important. So I'm going to establish the importance of data collection. I'm going to give some examples of what CDC is doing in order to try to work on improving those systems. And you heard a little bit about some of the recommendations about how we might be able to improve some of those. So maybe I'll talk about those a little bit. Let me give you a little bit of a story and hopefully kind of illustrate what I'm talking about in that regard. And for those of you who remember, I'm going to kind of take you back just a little bit. Some of you recall that there used to be string switches on lights. It used to be a little string, right? And you used to have to pull that string down. A few of you might still have those. In my house, there's one in the basement in the storage room. And you used to have to go into a room that was in the dark, and you had to kind of wave your hand around, right? Right? In order to try to, and oftentimes that switch was in the middle of the room. So you had to get to the middle room without stubbing your toe, without bumping into the chair, without tripping over the table. but you had to try to feel where it was in order to do that. But once you could feel that switch and pull it and turn it on, it illuminated the room, right? You could see what was going on, and so I'm going to try to make that connection, that that's what the data helps us to do. It illuminates what the patterns are. It tells us the who, when, where, and how of what that problem is. It tells us whether males die of suicide more than females, but females may attempt suicide more than males. It tells us about which populations might be at risk. It'll tell us a little bit about whether we're dealing with the Vietnam veterans or the Operation Iraqi Freedom or the Operation Enduring Freedom, the older adult veterans, the young adult veterans, which are the groups for which we can see the problem rising the most, which are the populations that are at greatest risk if we turn on that light, if we turn on that data, if we collect the information so that we know what's going on and so that we can demonstrate what's happening there. There's a number of different things, and part of when we try to describe that problem, and actually Senator Rounds really he was talking about the public health approach. I was like, wait a minute. We elected this guy? I said, I don't live in South Dakota, but I might vote for you. I'm going to do an absentee ballot or something. I was like, wait a minute, this guy knows the public health approach. I was astounded. Anyway, I shouldn't be too astounded, but he did a great job. He did a great job this morning. But there's many kinds of data that we have in terms of trying to identify and try to characterize the problem and try to see it from all of its different aspects. We have data that deals with fatalities, the death certificate data. We have different forms of looking at that. We have non-fatal data that looks at hospital emergency department visits, inpatient visits. We try to characterize that too. We also look at surveys. So that we can try to characterize those who say that they've made a suicide attempt in the past 12 months or have thought about suicide or are feeling hopeless or depressed. So we try to characterize all of those different things. And so I'll tell you a little bit about some of the stuff that CDC is doing. One of the areas that we have some information in is in the National Violent Death Reporting System. This is a system in which we link together 3 different data sources. We put together death certificates, we put together law enforcement records, and we put together medical examiner and coroner reports. What that does is it helps us get a better picture of exactly what's going on so that we know something about the circumstances about when somebody died. We know about whether they had a job problem, a crisis in the past 2 weeks, an intimate partner problem. We know about whether there was substance abuse. We know something about their medical history. So it helps us a little bit in trying to put together a better picture of what was going on in regards to the circumstances of the suicidal behavior that occurred, so that if we know something about those circumstances, if we know something about those risk factors, we're better able to deal with the next one and be able to identify where are the places we can try to intervene and try to make a difference. We also have some systems that try to look at non-fatal injuries. We have an emergency department surveillance system that's national, in which we can try to look at self-inflicted injury, try to characterize what's going on there. And so we know as a result of that when you look at non-fatal, self-inflicted injury, that females attempt more suicide than males do. So it's important for us to know that if our programs are going to be focused on whether it's preventing deaths, preventing non-fatal injuries, that we've got to be able to identify which populations there are there. And then there's also surveys, things like the National Survey on Drug Use and Health, the Youth Risk Behavior Survey. We know other kinds of surveys in which now we can get information, especially about health behaviors, that we can try to piece these things together and understand what's going on. Each of the systems has its own strengths and weaknesses. We know, for example, that when you're talking about deaths, it's really just the tip of the pyramid in regards to all of the things that are going on in regards to suicidal behavior. We know they vary in regards to what states can do and how they put together that information. The National Violent Death Reporting System, for example, is not in all states just yet. So we're still trying to expand that, and you can educate your lawmakers about why that's an important system. I said educate, right? I didn't say that A word. Can't say the A word. But you can educate your lawmakers. You can educate those decision makers about why that's an important system, so we can spread it out, so we can get that kind of information from all over. So we have that kind of information. We know that sometimes definitions differ. And that can make a difference too in how that data is collected. So it's important for us to use some standardized systems to try to define what's going on and to understand the problem. There are some strengths in those systems. You know, as I mentioned with the violent death reporting system, for example, it uses multiple sources. So once you start putting those together, you get a better picture. Some of those survey informations, while you don't get a lot of questions about suicidal thoughts and suicidal behavior, what it does do is ask questions about a number of other kinds of health behaviors. And now you can start to cross-match people that may have issues in regards to substance abuse, or in terms of anorexia nervosa, or in terms of bulimia, or in terms of other kinds of substance abuse questions, that now you can see, are these the same folks that are talking about suicidal behavior if you try to put some of those systems together? So it shows those kind of important things. It also demonstrates kind of the importance of partnerships. Because you're using different systems from different places, you're using information from the health department, you're using information from the schools, you're using information from, in certain states, child fatality review, in which you got social service contributing to what's going on. Now you can really find out more about what's going on, and you can really be able to demonstrate where there's a difference, where there was a possibility for intervening, so that you can make a difference in the next case. All of those things are kind of important, and I'm going to conclude here with a quote from Yogi Berra. So some of you are thinking, how in the world is Yogi Berra connected to suicidal behavior? And there's a number of different things. You know, those of you familiar, Yogi Berra, Hall of Famer in terms of baseball, played with the New York Yankees for many years. Many things that are attributed to him he didn't say, but there's a few that he did, and this is one of the ones that he did. And one of the things that he said is, if you don't know where you're going, you'll probably end up somewhere else. So what does that mean? What does that mean in terms of data? Well, if you don't know where you're going, if you don't have a vision, if you don't have a goal, if you don't have a target for where you're going with your program actually might be very successful in treating diabetes, or treating high blood pressure, or treating asthma, but you might not do anything for suicidal behavior. So you got to make sure that you know where you're going in terms of your program. You get in your car, you hop in, you're going to take a drive somewhere. You better pay attention to the route that you take, so that when you get to the end, you can turn around and make it back home. And you also better pay attention to the gas tank, right? Because you want to turn around before you get to about halfway, because if it's more than halfway, you may not make it back home. So you want to make sure that when you set your target for what your program is doing, that you know what your target is. You know where you're going. You know what your goal is. You know what your vision is, so that when you turn it around, so that when you see what kind of things are happening, you can tell whether you're making a difference or not. So I want to thank you all for your attention today. One other thing that I forgot to do at the very beginning is definitely acknowledge the survivors and acknowledge the families and those who've lost a loved one to suicide, because they are very important. As they talked about this morning too, that one of their big motivations is so that it never happens to any other families. And that's part of our job too, is as we're doing this work, is we're trying to prevent those deaths, those non-fatal injuries, that morbidity and mortality from ever happening again. Thank you very much.
Thank you, Dr. Crosby. I just want to briefly reiterate the importance of our partnerships with our federal partners, and I would also like to acknowledge my partner in crime from the Department of Defense, Dr. Keita Franklin from the Defense Suicide Prevention Office. She is the director. Raise your hand, everyone's looking behind you. She is the director of DISPO, the Defense Suicide Prevention Office. We speak weekly, if not more so, except for the last couple of weeks. But I'm just absolutely thrilled that she is here today, and really, we have so much incredible work to do together, and we're moving forward on that. With that, I'd like to introduce Dr. Meg Harrell. Dr. Margaret Harrell is the Executive Director for Force Resilience of the Office of the Undersecretary for Defense and is a Senior Fellow and the Director of the Joining Forces Initiative at the Center for a New American Security. Prior to joining the Center for New American Security, Dr. Harrell was a senior social scientist at the RAND Corporation, where her research addressed military manpower and personnel, military families, and quality of life. And it's a true honor to have her here with us today. Welcome, Dr. Harrell.
Good afternoon. So I'm Meg Harrell. I'm the new executive director of the Force Resiliency Office, which is a new organization for the Undersecretary of Defense for Personnel Readiness. The department created Force Resiliency in order to increase collaboration, promote synergies, and leverage our understanding of risk and protective factors across the organizations and issues in this portfolio. The Defense Suicide Prevention Office, and I'm thrilled that Caitlin already introduced Keita, but Dr. Keita Franklin runs DISPO for us. Suicide prevention is one of the most important and yet most challenging issues within this new portfolio. So it's an honor to be part of today's agenda with so many people from so many different inquiries focused on this very important common goal of saving lives. And I am just barely 60 days into this new appointment for the department, and so I'm increasingly aware of how challenging it is to stiff-arm the urgent in order to focus on the important. And when I look out and see a room full of people that have managed to focus on the important for this entire day, I'm thrilled to be part of this. And I'm proud to recognize the DoD, which has a long and rich partnership with the VA in this area of suicide prevention. Today's event is a really important opportunity to remember why we work so hard, and also to discuss the evidence and science and convert the expertise of so many important experts into policy decisions, directions, and actual decisions. Because quite honestly, speaking from the department, one of the challenges that we confront is assessing all of the programs that we have across DoD, all the many approaches. And how did this happen? Well, this happened because when we saw the numbers of military suicides increasing, leaders all across the department took action. And they took action because they were trying hard to protect and care for their soldiers and sailors and airmen and Marines. But now we have the challenge of determining what is effective and learning where we need to make adjustments in all those efforts. And so we're now transitioning to the coordinated approaches outlined in our just recently published Department of Defense Strategy for Suicide Prevention, which stems from the national strategy and the work done by so many of our colleagues at the National Alliance. And it's that strategy that provides the context for my comments today. Okay. So by training, I'm actually a cultural anthropologist. So I'd like to take advantage of that and highlight some of the ways that the military culture presents some unique challenges for us for military suicide prevention. So first, let me talk about the role of military leaders. Line leaders, like company commanders and first sergeants, squad leaders, platoon leaders, they believe that it's their responsibility to care for their service members, and that part of that is knowing everything they can about what's happening in their service members' lives. And the imperative of this is obvious to anyone in the military uniform, but it's foreign to those of us that had professional lives outside the military. So in general, a civilian employer won't know whether you receive a speeding ticket or overdraw your bank account or having relationship difficulties unless you choose to tell them. And likewise, your civilian employer won't necessarily know about the medical care you receive unless you share that information. But the military is different. Some service members may not want their military leaders to know that much about their lives, and it may put them at risk. There may be a Private Wilson out there that's having a lot of problems. They've taken his car, his wife has left him, but he's still motivated to wake up every day because he knows that he's a good soldier. He's hanging on to that. His leadership will assert that they need to know everything so that they can help him. But in that case, if his leadership learns everything about his life and what a mess his home life is, it may erode some of their trust and confidence in him, and he may lose that sense of purpose of waking up if he thinks that they don't believe he's a good soldier. So we're left recognizing that we need to balance the responsible role of the military leader with an individual's privacy, and we haven't yet determined that optimum balance. Another challenge involves our use of gatekeepers. Like the civilian world, the military recognizes the importance of gatekeepers. And perhaps the most important gatekeepers are their non-commissioned officers, NCOs, as well as chaplains. But we know from Dr. Rajiv Ramshad's recent important study that NCOs, when we studied them, about 40% of them believe that they would be held responsible for a death if they had previously spoken to that soldier about suicidal thoughts. So we continue to work to ensure that gatekeepers are trained and skilled, and also that they feel empowered and appropriate approaching a service member who may be at risk. And I also note that the civilian research suggests that female gatekeepers are more likely than men to reach out. And that's both an interesting and dismaying fact for us in the department, given that our population is predominantly male. By the way, shout out to Rajiv, also the co-lead of that groundbreaking caregiver study mentioned earlier today. So I'd like now to talk about the people that we're trying to help. Many of you know personally like what it's like to serve in uniform, or, such as in my case, what it's like to be part of a military family. But I'll reiterate some of the unique aspects of that life. First, many of our service members have deployed. And it seems intuitively obvious that we should be able to identify a link between deployment and suicides. And we keep looking, but we just don't see a definitive and direct empirical link. It's a complicated issue, though. We do see differences service to service, and we acknowledge that all deployments are not the same. The answer may be related to the nature of the deployment, the nature of the trauma that an individual service member experienced, but it's just not an easy answer. It's something that we will continue to look at. Reservists and guardsmen, they experience a unique set of challenges that stem from being geographically isolated and often living in areas far from traditional military support systems. They more typically live in communities where they are heavily invested and enjoy complex support networks, all a good thing. However, those family and friends may not appreciate and understand their military service the same way that their military service members that they served with did. As a result, when reservists and guardsmen return home, they may feel isolated despite that local support network and miss the camaraderie and cohesion of their unit. The geographic dispersion of them also restricts the ability of their leaders to assess their well-being. That first sergeant can't drive by their soldier's home and sense whether something's amiss. They can't stop by for a casual conversation. And that leader may not know that that reservist or guardsman has a problem until they don't show up for drill. And if they do assess that there's a problem, it's not always the case that that reservist or guardsman has resources that they can turn to. While the Affordable Care Act has increased the population with medical coverage, the quality and benefits of plans and care providers still vary. So what is DoD doing? Because we can't just stand by and say how hard it is. So we try to embrace the military culture to encourage service members to seek help. And I'll share one example of what this looks like. Envision a group of Marine recruits in basic training. Their drill instructor provides them with the following scenario. You're on a ground combat mission, you're surrounded by the enemy. It's not clear that you're going to get out alive. What do? Well, the correct answer is you call in support. You use the resources and the capabilities at hand to accomplish your mission, because that's what Marines do. Okay, now, you're in a personal scenario where you're surrounded by obstacles, and you're not sure that you're going to emerge alive. What do? You call in support, because that's what Marines do. So that's a very service-specific example, but it's a case of trying to use the military culture to operationalize and justify and stress that it's not just something you do on the side to take care of yourself, that it's part of being a military service member that you take care of yourself. We also empower the entire community to include family members. We've always recognized the important role of spouses in providing support to the service member, recognizing the risks of suicide, but each of the services are now offering formal training on suicide prevention for military family members. And regarding the risk of transition that you've heard about today, we've been struggling to assure that appropriate trade-offs occur, but we've gained some traction. So there's now the In Transition program, which ensures that military members who are enrolled in behavioral health care when they transition out of DoD's care are automatically enrolled in VA care. They have to opt out for this not to be the case. One very difficult issue that we're working on, we know the most common method of military suicide for both women and men is with a personally owned weapon. So the department has made some strides in this policy area with guidance to commanders and healthcare professionals regarding voluntary storage of weapons and how to engage on issues of weapon safety. But as a department, we recognize the need to develop a more comprehensive approach specific to means safety. And throughout all of these efforts, we emphasize the importance of evidence. As part of this emphasis, DoD hosted a research summit with the VA and with other key partners to develop a strategy focused on research gaps and ensuring that research is tied to current needs and to tough questions. We're converting that evidence emphasis into activities and programs. For example, we're now using the Columbia Suicide Severity Scale, a validated screener with 4 simple questions that's easily usable even by our non-medical personnel. And we continue to study the data and improve our surveillance. We're always looking for actionable risk information that can help our military leaders get to the left of potential problems. And collaborating with the VA will continue to be an important part of that analysis. Together, we need to understand our population across their continuum of service. We need to know what happens at the end of the story rather than just focusing on the chapters where we have them. And that's not the only way that we engage with our gracious and generous partners. The DoD and VA have invested together in workforce development. They're jointly hosting annual conferences that bring together hundreds of providers, academics, and policy analysts to share best practices and to learn the latest that science has to offer in this area of suicide prevention. This year, that work's been expanded to include 4 jointly hosted webinars. And DoD has also partnered with the VA for the last 2 years on the Power of One campaign, which aims to provide universal outreach to our active and veteran population alike, and emphasize that one small act can make a difference. One smile, one conversation, one caring comment. They can all change an outcome when somebody's at risk. So throughout all of these efforts, we're cognizant that our partnership and collaboration with the VA is vital, because we can each learn from the programs and the studies and the investments of the other. But even more importantly, because across time, we're caring for the same population. Together, we provide this lifelong continuum of care. Thank you very much for your time.